All right, so today I'm going to continue talking about hypersensitivity reactions, and then we will move into some discussion of some aspects of autoimmunity and also some aspects of general treatments that largely hit both hypersensitivity reactions and autoimmunity. So it sort of all goes together, because if you remember, I showed you last time this figure. It's way back, I have to scroll. That the 4 hypersensitivity reaction types that we are learning about, which are distinguished as having 4 different mechanisms, are actually the same mechanisms that we see for different autoimmune diseases. So when we can talk a little bit about some autoimmune diseases, it's going to be the same mechanisms that you are seeing with these hypersensitivity or allergy responses. And when we talk about transplantation later on, it'll be the same set of responses. So if you remember, we talked about type 1 last time. A type 1 hypersensitivity reaction is mediated by IgE antibodies. It is the immediate type response, but remember, it is really only immediate the second or later times. And the other things that are major participants in this response, in addition to IgE, are mast cells, which are going to degranulate because of the IgE that's bound on their surface, as well as mast cell products like histamine. Type 2 hypersensitivity is where we left off. With the type 2 hypersensitivity, again, an antibody is the problem. However, here that antibody is IgM or IgG. So now we have IgM or IgG. The other kind of key thing with a type 2 hypersensitivity reaction is that type 2 hypersensitivity reaction antigen is an antigen on the surface of the cell. So we specifically have either an IgG or IgM. The antigen is on the surface of the cell, and as a result, the antibody will bind to that antigen on the cell surface. And what will end up happening is that the cell will be killed or destroyed. That could happen by ADCC with NK cells. That could be complement-mediated lysis. That could also be sort of some phagocytosis types of stuff. So we can see a lot of different ways that this is going to happen. But again, key things: antibody and cell surface antigen. I also told you about an example of a type 2 hypersensitivity reaction last time, which was a penicillin allergy leading to hemolytic anemia, where we saw penicillin reacting with the red blood cell surface, so that we were making this new surface antigen on the surface of the red blood cells that could be bound by antibodies. The red blood cells could be destroyed. We would end up with anemia. There is another particularly famous example of type 2 hypersensitivity that I want to tell you about now to further explain this. And it also involves red blood cells. And here I am showing you some information about red blood cells and blood group antigens, just to clarify a little bit of this. So all of your red blood cells either do or do not have something called the Rh factor on their surface. So we can either have Rh positive or Rh negative red blood cells, depending on if you have the gene encoding this antigen or not. We also have a number of different sugars on the surface of the cells. And those sugars, you can see here, will distinguish between having type A, type B, or type O antigens. The particular sugars that you have will indicate whether you have type A, type B, type AB, or type O blood, depending on which antigens you have on the surface of your red blood cells. In basically all of these cases, These antigens, whether they are the Rh antigen, whether they are the ABO antigens, are pretty cross-reactive with some carbohydrates that are on the surface of a lot of bacteria in your GI tract. What that means is that everybody, when their B cells are developing, makes a B cell with an antibody against B and A and Rh. So we all make those when our B cells are developing. In some of us, those B cells get deleted during B cell development. So if you have type A blood, the B cell that made the anti-A antibody would get deleted during development because it's a self-antigen. And the one that made B would stick around. Same if you had B, the anti-A would stick around. If you had AB, neither would stick around. If you have O, both will stick around. If you're Rh positive, the Rh B cell will get killed. If you're Rh negative, the Rh B cell will not get killed. Because these antigens are also present, or cross-reactive versions of them are present on microbes, these B cells will get primed and will actually make okay amounts of these antibodies. So not only do you have the one B cell, that one B cell actually gets a signal and so makes that antibody. So if you are a person who has type A blood, your blood actually also contains antibodies against B because you didn't kill the B cell, and the B cell actually got some signal in order to make some antibody. Similarly, if you have type B blood, you have some type A antibodies. If you have type O, you're making both. If you have Rh, if you're Rh positive, you are actually you're not making the antibodies. If you're Rh negative, you're making those antibodies. So that's kind of big picture how this is going to work. We'll talk about this a little bit more when we talk about transplantation as well. But these antigens, you can realize, are cell surface antigens. That's kind of like the point, is they're on the surface of these red blood cells and could potentially be bound by some of these antibodies if those antibodies are present. Fortunately, in general, those antibodies are not present because you deleted the B cells that would make those self-antigen antibodies during development. However, there is a problematic situation that can relate to this. It is known as erythroblastosis fetalis, also known as hemolytic disease of the newborn. And what can happen here is that we can have a mom who is Rh negative. So in mom, the Rh antigen is foreign. She actually probably won't have a ton of anti-Rh antibodies. It doesn't prime the same. The A and the B prime a lot. Rh doesn't really prime in the same way, at least to that same degree. But it's possible that mom can be pregnant with a fetus that's Rh positive. That, of course, would happen if dad is Rh positive and dad contributes the Rh gene. So mom's Rh negative. She does not have this Rh antigen. Baby's Rh positive. Everything's fine during the pregnancy. But during delivery, mom is going to be exposed to some of the baby's red blood cells through the placenta or otherwise. And so you can see that some of those red blood cells are going to come out, and mom is going to suddenly be exposed to them. And suddenly she's going to be exposed to this Rh antigen that she hasn't really been exposed to before. And so you can ignore what I said previously about a little bit of priming in Rh. Yes, priming AB, no priming Rh. I apologize for that. But in this particular case, now she is getting primed with Rh. So now her B cell that is specific to Rh, that was never deleted in her, because it's not a self-antigen in her, so she has that B cell hanging out. suddenly that B cell is going to become a memory B cell and start making IgG. This is fine. She's now going to make this antibody. It's going to be basically kind of a useless antibody in her body. Nothing really is going to happen. She's already done with that pregnancy. Baby's already out. We're good. However, if mom gets pregnant again with another Rh positive fetus, now there's going to be a problem. Because IgG antibodies are able to cross the placenta. And these IgG antibodies are going to cross the placenta and are actually going to attack the fetus's red blood cells. And so the fetus is going to lose its red blood cells. In the end, the baby will have severe anemia because of a lack of red blood cells. There will also be some breakdown products of hemoglobin and other things, and so the baby will actually have a lot of issues of sort of some of these excess toxic products that are coming actually as a result of the red blood cells dying. And so this baby will be in pretty severe shape. This is not good. Fortunately, we know some things about immunology, and we know a way to actually prevent this from happening. And so we can actually prevent this. This is actually relatively rare here. And the way that we prevent this is that if mom is an RH negative mom, we do some blood typing when someone is pregnant. If mom is Rh negative, and if she has an Rh positive fetus, she will get treated with something called Rhogam. Rhogam is an antibody. And specifically, Rhogam is an antibody that will bind to those red blood cells, the Rh positive red blood cells. So it's an antibody against the Rh positive red blood cell. And as a result, we get this process happening. So normally, we would have those red blood cells stimulating naive B cells and turning on those naive B cells to make IgG. And then those B cells would kill, or those antibodies, the IgGs that are made, would kill the red blood cells. If we treat with Rhogam, Rhogam is going to bind to the red blood cell, as well as binding to the Fc gamma receptor on the naive B cell. That Fc gamma receptor gives a negative signal and turns off the B cell. So if you remember when we talked about naive and memory responses, we talked a little bit about how when you make a memory B cell response, you don't want to waste your energy on also turning on more naive cells. You want to focus all of your energy on turning on memory cells. And so we talked about how you turn off the naive B cells. If antibodies are present, naive B cells can't get turned on. And so we use this knowledge and we treat the mom with antibodies. So now she has IgG present during that first pregnancy. And because that IgG is present, it turns off naive B cells. It makes it so that they cannot be activated. And so now she's not going to ever make a memory B cell response of her own. She's not going to make an IgG response of her own. And she's going to be protected from making this response and harming the baby. So she's given Rhogam, this antibody that's shown here, to actually inhibit naive B cell activation so that she does not have any of this production of her own B cells making this response to potentially cause harm during the second pregnancy. Yep?
Would it be possible
Can you give me an example of how you're thinking about it?
I'm just thinking because, like universal donor blood, a lot of times there are shortages.
Mm-hmm.
So, I mean, specifically, I suppose, with RH, because we already have the antibodies in our body for A and B.
Yeah, I think that there are probably better things that you could do to try to pull some of the antibodies and just transfer, say, purified red blood cells or something like that instead of trying to do it that way. So I think that there are other ways that you would go about answering that question, doing this issue. Yep.
How early do they test the fetus?
I think they do them pretty early. I actually am not sure of the exact timing of the testing here, but they do all of this relatively early.
And there's also chat.
Oh yeah, sorry. I actually noticed that before, and I was waiting to, and then I forgot. So the question is about whether this would pose a problem to the first newborn from passage of the IgA through the breast milk, whether we could have this problem, and we really don't. IgA is not going to lead to lysis, particularly complement-mediated lysis, which is the real issue here most of the time, nor is IgA going to lead to NK cell activation. And so this is a very IgG or IgM specific thing. It's really an IgG specific here. It's not going to be a problem with IgA through breast milk. All right. So, and then I told you a little bit more about the penicillin type 2 hypersensitivity last time. So we can move on to the type 3 hypersensitivity response here as well. So type 1 had another name, which was immediate type hypersensitivity. Type 2 doesn't really have another name. It's just type 2. Type 3 also has another name, and that is immune complex disease. And so this came up in Monday's class, where we were looking at a table of autoimmune diseases, and someone asked me about immune complexes. This is immune complex disease. So with type 3 hypersensitivity, again, your problem is an antibody problem. And again, just like we saw with type 2 hypersensitivity, the antibody in question here is an IgG or an IgM. The difference with a type 3 hypersensitivity reaction is in the antigen. Now, the antigen is shown here as a little green oval. The antigen is an antigen that is a secreted protein. It's not on the surface of a cell. It's a free protein, or a soluble protein. As a result, what you might notice here is that there's no cell at the top. So we can't have a cell get killed. There's no cell to be killed. Instead, the problem that comes up when the antigen is in this form is that we make things called immune complexes, which are antigen-antibody complexes, where you'll have multiple antibodies binding to the same antigen, often multiple antigens binding to the same antibody. So you can see this antigen has 2 antibodies bound to it, and this antibody has 2 antigens bound to it. And so we don't have just kind of one antigen and one antibody here. We have this whole big clump of antigens and antibodies coming together. And those are called immune complexes. Those immune complexes are what are causing our damage here. They can cause damage in a few different ways, which I will show you on a couple of subsequent slides. So when we think about immune complex formation, one thing that it requires is that we have just right levels of antigen and antibody. if we have the situation that's shown on the left, where we have a lot of antigen and a little bit of antibody, we won't get immune complex formation because we won't be in a situation where it's likely that any antibodies will share antigen. You can see there's so much antigen, they're not going to share, they can all have their own. If we're in a situation where there are lots of antibodies and few antigens, you can see, again, that we're not really going to get this sort of cluster formation happening. You can see, there's maybe a situation like that where you have one little clump together, but really they're all going to be separate. But if you have kind of just the right concentration of antigen and antibody, then you can get these large, higher order structures of immune complexes. And so this has to happen in kind of, again, a just right amount, a just right kind of situation. And that can be limited to certain situations happening. When these immune complexes are formed, they can cause quite a bit of damage. So one of the things that they can do is shown here, which is that those immune complexes can start activating complement in particular parts of the body and actually lead to mast cell degranulation and lead to inflammation. So we can get complement formation, inflammation happening. And having random inflammation happening in your body, it's not really great. And sometimes that inflammation will be, say, at the wall of a blood vessel. Because these immune complexes that are going to be traveling through blood vessels and stuck. They're kind of big and can get stuck places. And if they get stuck on the wall of a vessel, then you're actually going to have an inflammatory response attacking your blood vessel walls, leading to things like vasculitis. And so you're going to get some injury there. Blood vessels, however, are not the only place they could get stuck. And before I go into some of the other places they can get stuck, I want you to think about this for a second with this blood vessel. Let's even imagine this before we go into inflammation. Let's just think about this blood vessel. And let's imagine this was a gigantic immune complex, like the one that was shown here, with tons of antibodies and tons of antigens. Can you imagine any other reason why it might be bad to have that immune complex here? Yeah. Yeah, you're actually going to impede blood flow. You're going to actually have something getting in the way, making it hard for blood to go through. And so you're going to stop flow of, in this case, blood. As I mentioned, immune complexes don't just get stuck in vasculature. Immune complexes can also get caught in the skin. They can get caught in the tubules of the kidney, which are trying to filter the blood. They can get caught in the joints, or they can get caught in the small parts of the lung where blood is going through to get oxygenated. You can imagine all of those are things where you could easily have things get caught in circulation. You could also imagine how bad it would be to have inflammation in any of those locations, and how bad it would be to have any of those not have full flow through them, not have full transport. And so we can end up with things like Arthus reactions, which are skin, and I'll show you an example of that. We can end up with vasculitis. We can end up with glomerulonephritis, which is a kidney disease. We can end up with arthritis when we're getting deposits in the joint. And so wherever those immune complexes are depositing, they can cause both inflammation and also obstruction, which is not good. So none of these immune complex diseases sound particularly great. We don't want them. The famous example for a type 3 hypersensitivity or immune complex disease happens when people are undergoing something called passive antibody therapy. And so we've talked a little bit about passive antibody therapy before, but I want to remind you about passive antibody therapy. So with passive antibody therapy, we will take antibodies from an immune individual, so somebody who has made an immune response. We'll take their blood, we'll get just pooled antibodies from their blood, and we can inject those into another person so that that person now has antibodies to block the response, and that will allow this person to recover and to be immune. This is a really great treatment for a number of different types of things. There are situations where you might have heard of this being used for COVID, among many others, where the idea is, you don't want to wait around for the person's immune system to do its work and make its own response. You want to give them antibodies now. You want to wait all that time for that adaptive response. So you're going to give them antibodies now. That's the pro. The con, of course, is that their B cells don't get to participate, and so they don't actually make a response of their own. They're not going to have memory because their B cells didn't ever do anything. But you protected them right now, and that's really key. Some of the situations where passive antibody therapy is used are shown on the right in this table from your textbook. And so you can see this here. If you get a black widow spider bite, you do not want to wait around for 2 weeks for your immune system to make an adaptive response to make antibodies against the toxin. You need antibodies now to make sure that you don't die from that toxin. And so you're going to get passive antibodies given to you. If you have botulism, you're going to get passive antibodies. If you get snake bite, you might have passive antibodies. All of those kinds of things. So you can get a quick response. So we're going to kind of think about the case of the black widow spider bite. So if you get a black widow spider bite, like I said, we're going to give you antibodies. Those antibodies were made in a horse. See, it says horse antivenom. So what that means is that somebody injected an antigen into a horse and got that horse to make a lot of antibodies, and then got the antibodies out of the horse, and had it in their fridge so that they could protect anybody who gets a black widow spider bite. Why do you think you use a horse? Yeah, Jamie.
Is it like about just sheer mass that they can make a lot of antibodies?
Yeah, a horse is really big. You can get a lot of antibodies from a horse. Okay? Pretty easy. Okay, so let's imagine you get a black widow spider bite. We treat you with passive antibody therapy. You live happily ever after. Now let's imagine you get a second black widow spider bite. Question number 1, what is going on in your life? If we pass that part of the question, you get a black widow spider bite, you might actually, a second time, you might actually have a problem if I treat you with the same passive antibody therapy. If I treat you with this, so again, don't overthink this one. What kind of biological molecule is an antibody? For example, is it a lipid? No. What is it? It's a protein, right? So when I treat you for your first black widow spider bite, I am injecting a whole bunch of horse protein into you. Are you a horse?
No.
Good job. Good answer. Nay. So what's going to happen if I inject a whole bunch of horse protein into you? Yeah? You're not going to reject. The rejection is more of a organ thing, but it's related. Yeah.
Well, you're going to create antibodies against the horse protein that you just put in.
Yeah, it's a foreign protein. So we're not going to go to full rejection, but you're going to make an immune response against it. You're going to make an immune response against this foreign protein. You're going to make an immune response against horse antibodies. You're going to make an anti-horse response. Which means if I then say, oh my gosh, you got a second black widow spider bite, I got to treat you again. I inject you with more horse antibodies. You're going to make an immune response against the horse antibodies. You're going to make it, and you're going to have a response to those. What you will notice is you will end up, in many cases, with something called serum sickness. Sickness that comes from getting treated with the serum from the horse. There's one piece of this that always confuses people because of the way this is labeled. So this shows us an antigen in yellow getting injected into a vein. In this case, the antigen is the horse antibody. So I treat you with the antigen, aka horse antibodies. You're going to have a lot of it in your body, right? It's a protein. It's eventually going to break down. You're going to get rid of it. Over time, you're going to have antibodies that your body makes against the horse antibody. So this is your anti-horse. And those are going to increase over time. At some point, you're going to be at that zone of just the right amount of antigen, just the right amount of antibody to make immune complexes. And this is particularly problematic, again, the second time through with your horse antibodies. And during that time, you'd be in this blue triangle where you get antigen-antibody complexes formed. And you can start to get a type 3 hypersensitivity reaction to having those antibodies, which will cause disease. So this is what serum sickness ends up looking like. So typically, you're going to end up with immune complexes in blood vessel walls, and so you'll get in the skin. So you'll actually get these types of rash as well as some vasculitis. You will probably also see some issues with kidneys and issues with joints because of the deposition of those immune complexes. There are some situations where this can all happen subcutaneously or in the lung as well. But usually when we think about this, a classic serum sickness is the skin, vasculature, and the kidney and joints. Yep.
So the only reason you can get the foreign antibody is the time it takes for your body to make an antibody against that?
Exactly, yeah.
Okay.
So sort of at the beginning, you're okay because you haven't, unless you have previously made responses to horse, again, I don't know what's going on with you in that situation, then you're good. So it's kind of like the other ones in that you need to be sensitized first. And so you need the time for sensitization, but then this can go to a bigger problem the second time through. Yep.
I have a couple questions about immune complexes in general.
Okay.
When we're talking about the vasculitis, does that ever get to the point where it completely cuts off blood flow?
It theoretically could.
Okay.
I cannot think of a specific example, but theoretically it could.
Okay. And then with the immune complexes, if someone, let's say, has like rheumatoid arthritis,
Mm-hmm.
do they have a higher chance of those immune complexes spreading to other regions, or do they tend to stay in the one specific region?
I mean, in the rheumatoid arthritis situation, the joint surface is just such a good place for them to deposit. And again, you don't have complement inhibitors there, so you can have a lot of complement activation. They could go to other places, but they're probably not going to be quite as dangerous as they might be in the joint, where there's so much destruction they can do and so little that we can kind of do about it. So they could potentially spread, but the joint is where they're really going to be problematic. All right. So that was our type 3 hypersensitivity response. And now we can talk about our type 4 hypersensitivity response. Like number 1 and number 3, number 4 also has another name. The other name for number 4 is a delayed type hypersensitivity response, or sometimes known as a DTH. So I usually refer to these as a DTH. A delayed type hypersensitivity response can happen in response to a number of different antigens. Some of the key antigens here can be poison ivy and poison oak. So this is a poison ivy, poison oak response, as well as another kind of famous one is nickel. If you ever have had basically an allergic reaction from wearing cheap jewelry, that was a nickel allergy. Because my immune system apparently only likes to pay attention during this set of lectures, I'm real good at having nickel allergies too. So, and in fact, it's showing a piercing having an allergy in this image here. And there also are some examples of these responses with some microbes. I will talk a little bit about the mycobacteria example as well. The key thing about a delayed type hypersensitivity response, as you might guess, is its timing, that it has delayed in the name. So the timing is going to be important. But when we think about a delayed type hypersensitivity response, or a DTH, the thing that's also really key here is that this one is not antibodies. So the other 3 all involve antibodies. A DTH response involves T cells. And so this response involves T cells causing problems instead of antibodies causing problems. Also, just like what you've seen with other responses, we went through this in the most detail for a type 1, but based on the questions people were just asking, it is also true of others. There are kind of 2 phases here. You have to first become sensitized before you actually have this response. So the first time you encounter poison ivy, you're not necessarily going to have much of a poison ivy response. But the second and later times, you will make this response. The first time you wear the cheap nickel jewelry, no problem. Later times, you get the response. During that sensitization phase, that first time where you have no problem, you are actually having the antigen presented by antigen-presenting cells, and you are having the cells become activated to make Th1 cells. So you're going from the Th0 to the Th1 response, and you're making a large Th1 population. And so generally, when I think of a DTH, I always think of Th1 cells. And so the first time you encounter that antigen, you're turning on Th1 cells. This second time you encounter that antigen, now the Th1 cells are going to do something. Those Th1 cells are going to make a lot of cytokines, as well as activating macrophages. And this is the effector phase. And so once you see that antigen the second time, that antigen is going to have to be picked up by antigen-presenting cells. It's going to have to go to a lymph node, turn on the T cells. The T cells are going to have to come back to that area and actually start to make an inflammatory response. That inflammatory response is going to do things like give you an increase in vessel diameter. It's going to do things like give you a change in vascular permeability. It's going to do things like give you influx of cells. And so you're going to get a swollen area, some kind of little blister, some kind of little visible lesion. All of this processing time and time for the cells to travel is going to take a little while. And so you're not going to see this within minutes like you would for a type 1. You are going to see this response 24 to 72 hours afterwards. And that 24 to 72 hours is the time for the antigen to get presented and go to the lymph node and the T cells to get activated and go back. These are memory T cells, so they don't take a whole long period of time, but it's still about 24 to 72 hours before you actually are going to see this type of lesion. So the one example of this that is most famous to people is the contact hypersensitivity response, aka the poison ivy response. And so here we have a plant. It is making this compound erythritol, which is shown. And that compound, if you are in contact with it, actually goes into your body and modifies a self-protein. So it reacts with a self-protein and makes a new antigen. That antigen will then sensitize your T cells. And so the first time you come in contact with this antigen, you're just going to activate a bunch of Th1 cells. The second time, you're going to activate those Th1 cells. They're going to quickly be able to make their way back to that area of the skin where they're going to lead to an inflammatory response. And you're going to have fluid come in, cells come in, redness, all of the things you think of with an inflammatory response, and you're going to get the traditional poison ivy rash because of those inflammatory cells coming in. And so that's what's going on in that delayed type hypersensitivity response, or in the nickel allergy, or in whatever. Does this make sense? There is one other extremely common application of a DTH response, or a situation that may come up for any of you who have spent any time in healthcare systems. This may have already come up for you. If not, it will come up for you in the future. And it's something called the PPD. PPD is a test for tuberculosis. So just to give you a quick primer on a couple things about tuberculosis. Tuberculosis is caused by a bacteria of the genus Mycobacterium. In fact, there are a number of infectious diseases caused by different members of this genus. So one thing that's a problem with tuberculosis is it can enter a latent stage in the lung. And so sometimes you can have tuberculosis. It can be in your lung, but you might not know it. You might be like, I'm totally fine, because it is in your lung. And it is controlled usually by a Th1 response. But you could imagine it would be kind of bad, or at least you would want to know if you were in a healthcare setting and you had tuberculosis in your lung before you, say, went to work as a physician or in any other way in the healthcare system. There's one way we could check to see if you had tuberculosis in your lung. What is sort of, again, not thinking about the PPD right now, what's sort of a just general way you could imagine that you could look in someone's lung and see if they have tuberculosis? How could you look in someone's lung? Yeah, Rishi? X-ray. So you can do chest X-rays, and you can actually see lesions in the lung. It's not like a super easy, quick thing to do. Also, might not want to, like, I don't know, give all of your healthcare professionals x-rays every 6 months. That might be a bit of a radiation exposure. Kind of costly, you know, kind of seems like a lot. But it'd be really bad to have them have unknowingly be positive for this bacterium. So fortunately, we have this other way of testing called the PPD. So with the PPD, what we are doing is we are taking a protein from Mycobacteria. It's a protein, it's purified from a member of this genus. It's known as the purified protein derivative, or PPD. So it's just purified protein from this microbe. And we are injecting it intradermally. So we're basically injecting it directly under the skin. If you have tuberculosis, you will already have some Th1 cells able to respond to that microbe and to that to the epitope and the antigen, really. And so if you have tuberculosis in your lungs hiding, you are going to have some Th1 cells already ready to go. And those Th1 cells will actually traffic to your skin and will give you a reaction. And so if you have Th1 cells, that means you must have previously been infected with, or you must be currently infected with this microbe. And so we can just look to see if you make a reaction in your skin to tell us whether or not you have this. You specifically look about 48 hours after, because, as I told you, a DTH response takes about 48 hours after responding to antigen. There's a very specific definition for a positive here of you have to have a certain amount raised and a certain amount red in order to get a positive. If you've never been infected with this microbe, then you will not have a response, and so your arm will be sort of clear. If you have it, then you'll have this red bump. And so that's actually how we do most of our tuberculosis testing, because it's very kind of quick, easy, safe, all that good stuff. So this is how we test for tuberculosis. Many of you may have had a PPD before. There are lots of complications with PPDs. I see some hands, so that we might be talking about those. Yes? So what happens if you have multiple tuberculosis tests in your life? So it turns out, and I know this from experience, that you can actually basically you make a different type of hypersensitivity response if you get them too often. It is not the traditional red and raised. It doesn't go to a Th1. It actually becomes more of a Th2, and so the way your arm looks is different. This is pretty rare. It also only happens to people with absolutely no melanin. In my case, I was in a lab where I wasn't working with mycobacteria, but some of my friends were, and so we all had to be tested all the time. I got sensitized and actually got a reaction. It is not at all this reaction. Basically, my entire arm turns red, but doesn't raise at all. But it's like my entire arm turns red, and it's a little early, but also lasts for a week. And so then, in that case, you get to argue with doctors about the meanings of induration and arrhythmia, and what the definition is and what you're seeing in your arm, which they really love a lot. Also, it turns out that this was all designed as an intradermal injection, so it goes under the skin. It turns out that the other hypersensitivity response is actually not from the intradermal. It's from the fact that what they do is they take the needle, they go into a little vial, and they pull up some stuff, and a little bit of it gets on the outside of the needle, and that goes subcutaneously instead of intradermally. And so if they actually cleaned the needle, or if they took the needle off and put a fresh one on, I wouldn't get the response. They also really don't like it if you tell them that, and try to tell them how to do their job in that way. You can get a response. It has to do with frequency. So now that I don't get PPDs every 4 months, that response has gone away. And so I'm not making that response anymore, but I was then. And then you get to do just lots of arguing. If you test positive in general, they send you for chest x-rays. Yeah.
What's the difference between this test and a typical TB blood test?
With the typical TB blood test, I think it's actually trying to do this in a well of a plate instead of in your arm. The other, I guess, piece that relates to all of this will come up more next week, is that there is a tuberculosis vaccine that is used in some countries, not in the United States, because it kind of sucks a lot. And one of the cons of that vaccine is that it does make you PPD positive. And as a result, you can no longer be tested with this. You have to get chest x-rays to be tested. So that becomes a whole other issue. And one of the reasons, in fact, why we don't use that vaccine in the US is because it lets us use PPDs quickly and easily. And the vaccine sort of would not be useful for our purposes. So that's PPD. So I'm going to sort of switch gears now into thinking about disease states that are really autoimmune diseases and how those autoimmune diseases are happening. But I also want to, in sort of my transition, just mention that there are an awful lot of diseases that kind of skirt the lines here. Officially, hypersensitivity is a response to a foreign yet harmless antigen, and allergy is response to a self-antigen. Yes, autoimmunity. Thank you. But sometimes the problem that we're seeing with certain disease states is just excess inflammation. It's really an innate response, and so makes it hard to say what's the antigen, because here we're really just talking about excess inflammation. And more diseases are being linked to kind of a chronic inflammatory state. And so that makes it really hard to understand what the problem is. Similarly, there are situations, like if you think about the poison ivy example, it's a self-protein that was modified by a foreign thing. So again, it feels a little bit wonky in terms of how you put it into one of those criteria. And there are lots of diseases, more and more, that are getting classified as inflammatory diseases or autoinflammatory diseases that are just really hard to place in one or the other. One of those diseases that's really hard to place is celiac. So with celiac disease, what happens is that when you eat gluten, that gluten is broken down into a peptide. That peptide is then acted upon by another enzyme in the body. And then this modified peptide gets presented, and we get excess inflammation. So it's hard to say this is totally an autoimmune disease, because I am not bred, or a person is not bred, so it's not really like self. But we're actually not having, but we have to have self enzymes to make the modifications. So it's not that we're totally acting on a totally foreign thing either. And the problem is all caused by excess inflammation anyway, not direct destruction of the cells that are getting too much inflammatory cytokine. So these diseases can become very challenging to differentiate. And so with the diseases I'm going to tell you about for the rest of the time today, most of them are actually some that are sort of pretty clean in terms of some pieces of what we know about how they happen, but realize that sadly most autoimmune diseases are not as clean as I'm going to make them out to be on the next few slides. Most of the diseases I'm going to tell you about now are described as antibody-mediated autoimmune diseases. So they have antibodies that are causing the problem. If you recall from stuff I've told you about before, even when we say they are antibody-mediated, it's probably not perfect that they're antibody-mediated. You need some T cells to make the B cells class switch and things like that. These antibody-mediated diseases in general are going to look in some ways similar to some of the things that we've seen before with some of the hypersensitivity responses. When we think about those antibodies can often act in a couple of different ways. One of those ways is exemplified by Graves' disease. And so you can see Graves' disease here. Normally in Graves' disease, or normally without Graves' disease, we have the pituitary. It makes some hormones. You can see it makes specifically this thyroid-stimulating hormone, TSH, which binds to a receptor. When that binding event happens, that turns on cells in the thyroid to make thyroid hormones. So basically the pituitary says, turn on. The thyroid says, okay, and makes some thyroid hormones. In the case of Graves' disease, patients make antibodies to the thyroid hormone, TSH, thyroid-stimulating hormone receptor. And those antibodies are activating antibodies. They bind to this receptor and they signal. They make the receptor signal. So the receptor thinks it has received TSH when it has not. So the thyroid starts making thyroid hormones when it is not time to make thyroid hormones. So we have an overactive thyroid in Graves' disease. And so here, these autoantibodies are turning on excess production. They're activating something that should not normally be active. And so the thyroid is making excess thyroid hormones. And so here, one of the ways that we can see antibodies acting in some autoimmune diseases is that they turn on things that shouldn't be turned on. They are activating antibodies. Yep?
Is Graves' disease the same as hypothyroidism?
There are multiple types of hyperthyroidism. Graves' disease is one type. Alternatively, other antibodies can act as blocking antibodies. And this is exemplified by a disease called myasthenia gravis. So normally, we see what is happening on the left, which is when a nerve wants to talk to a muscle and tell that muscle, hey, muscle, do your thing. The nerve will make some of this neurotransmitter, acetylcholine, that will interact with the acetylcholine receptor to make the muscle activate. So that's what normally should happen. In myasthenia gravis, patients have antibodies that bind to the acetylcholine receptor and block the acetylcholine receptor so that the acetylcholine can be made, but the receptor cannot get it. The receptor cannot receive it, and so we can never actually turn that muscle on because the muscle is not going to be able to get the signal. And so this is the exact opposite, a blocking antibody that is helpful for, or that is leading to myasthenia gravis. With some of these antibody-mediated diseases, there is also a potential problem in that some antibody-mediated autoimmune diseases can transfer short-term from mother to fetus if the antibodies cross the placenta. So if the autoimmune diseases involve an antibody that is of the IgG isotype, and mom has the autoimmune disease, mom has Graves' disease in this case. Graves' disease does, in fact, lead to some changes in the eye. So I think what they're trying to show you is mom's eye here. The antibodies can cross into the fetus. The fetus can actually have their thyroid attacked and have Graves' disease. This is not going to be lifelong in this fetus because we only have antibodies transferred, not actual B cells. So basically the baby's going to have Graves' disease just for as long as the mom has it, just for as long as the antibodies persist. When the antibodies degrade, because they're proteins, they're going to degrade with some half-life, then the baby's going to be okay. And so because of this, if a woman has Graves' disease, she will have plasmapheresis to actually try to remove those antibodies from the baby's circulation. And so that can be, those antibodies can be removed, the baby can be cured. Because the baby doesn't have its own B cells making these problematic antibodies, it's just mom's B cells. So if you look at some of, say, myasthenia gravis or Graves' disease, these antibodies are binding to antigens that are pretty localized in the body. And so we're going to have a pretty local response. You know, it's only going to be the thyroid here. We're not going to have antibodies attacking throughout the body. We're only going to have antibodies at the neuromuscular junction here. There are also a number of autoimmune diseases that are immune complex mediated diseases. And exactly how they end up presenting in a patient can look really different based on what the antigen is and whether the antigen is found in many different places. I'm not going to have a ton of time to tell you a ton about lupus right now. I may not end up having much time to tell you much about lupus in general. But what you should notice is that these are actually the antigens in lupus: DNA, histones, ribosomes, and some other things that are found in the nucleus. Realize those are everywhere in the whole body, which is part of the reason why lupus has so many symptoms impacting so many body systems, because it's not like you have a localized antigen. You've got antigens everywhere, and so kind of your entire body is sort of game for those antibodies to attack and cause immune complex disease. If you've heard anything about lupus, it's often known as the great imitator because it has symptoms that are so similar to so many other symptoms. It's very hard to diagnose. If you ever watched House, it was like a running joke on House, where basically the residents always wanted to diagnose whatever random thing it was as lupus. And you can actually find, and he would always be like, "It's not lupus." And you can actually find compilations of just him saying it's not lupus over and over and over again from so many episodes. Because lupus can be so different from patient to patient because so many different parts of the body can be affected given the sort of ubiquity of the antigen. So I will see you guys in lab tomorrow.